So what I'll do is I'll demonstrate the template now. Actually, I'll quickly demonstrate how you can all access the template first. So I'm going to need to change screens. So I'll load up a test patient. So I just go into a new encounter as I would normally when I'm opening the chart. And then visit templates is something you'll have to add to your system, to the action list. If you can see, there's my new encounter, there's my action list, and there's my prescriptions and pathology and things. And down the bottom here is the visit templates. And if you don't have that, you just right-click on that little gray screen, select preferences, and then you need to tick off that the visit template is accessible, which is there. So you check that box. And what I suggest is for all of the physicians in your clinic, just get the MOA to do that quick step for you so that it's there. You don't have to think about that. And you only have to do that once. And then once you've got the visit, so you go to visit templates, and then the first time you use the visit template system, like a lot of things in Intrahealth, there won't be a most used populated list because you haven't used it before. So to find the pain template, you just go to the look for menu, type in pain. I don't know sorry if you can't see it, but you'll be able to get a video of this zoomed in. And then there's the chronic pain visit template is the PSP pain module template. And there's two ways you can access it. You can either double click on it, and it will ask you to add, it'll ask you to add what parts of the pain template you want to add. Or my preference is I just drag it into, hold down the left-hand mouse button, drag it into the new encounter, and it does that automatically without making that pop-up screen happen. Takes about 10 seconds to load all of the visit template items. And you'll see it's not actually made any text happen in the encounter yet, but what it's done is given me a bunch of uncompleted action items on the right side. And those action items are visit templates, or patient information leaflets that I can print, or patient information leaflets that I can open, forms that I can open to help me score the pain catastrophizing scale or the opiate risk assessment tools, etc. And I'll quickly show you one of them, how you open it, but we'll go through it when we go through our case study as to how we do it. So if I'll show you a typing template for the initial pain visit. So again, you can either drag it or you can just double click on it. And when you double click on it, it populates the visit template. And it's a bit glitchy because it starts off at the bottom of the screen at the moment. I'm going to fix that. But then you can go through the chronic pain template by pressing F4. If you didn't know that, there's diamonds. In here, there's diamonds that placeholders for you to move between different areas of the visit template and record your text. So you press F4 and you can move between all of those. And sorry for the poor resolution, but it's got lots of helpful parts, suggestions in the template as to what you can do and how you can activate different parts of the visit template. And then there's other sections of the action list here. So patient information sheets, for example, for the pain disability index. If I double click on that, it will access the system and open a PDF or print a PDF for the pain disability index or brief pain inventory. Well, I'll go through the case study, and I'll just be demonstrating how we use the visit template. So Brad Stevens is an acute shoulder syndrome, and this is a real case, but obviously anonymized. So 38-year-old single man, acute shoulder injury 3 days ago, wants something for pain. He's a busy manager of a golf club. It happened on the May long weekend. He was at a couple of wedding receptions. He just had to get things done. There was something heavy. He was pulling on the cart, didn't realize the cart was stuck, and he yanked on it and wrenched his shoulder. So he's got an acute right shoulder injury. Any movement is excruciating. He's not sleeping due to pain. He's been trying some ice and using Advil. It's usually worse in the morning, and he's finding it difficult to move his arm. Feels completely disabled by this. As he's busy season, not got many staff, needs to keep at work. We've all seen this kind of story before. And usually the first visit, I wouldn't necessarily consider him to be a pain patient in the first visit because he has an acute, realistic, reasonable reason for his pain. So I would usually document the physical findings, and I wouldn't do the visit template in this first visit. I would just do a SOAP note. But the physical findings are he's tender over the biceps tendon and the anterior shoulder, and he's got pain on with all main range of movements of his shoulder. 2 weeks later, he's on a Thursday. He's been following the advice religiously. He's been avoiding load on his shoulder. He's doing the range of movement drills, the pendulum exercises. He's taking Advil. His pain when he's not doing anything is worse than it's ever been. Not able to sleep. He's got a really busy weekend again. He really wants to take something to get himself through his job. A friend has given him a couple of Percocets, and he was able to sleep a bit better. So no changes in his physical exam, and he's asking for more pain relief. So this is probably when I would start opening the first template of that pain visit template. So I'll show you that again. On the Intrahealth thing, this is the initial visit for chronic pain, or not necessarily chronic pain, but I would certainly add the visit template and start maybe considering using some of these tools, so the brief pain inventory, to better establish what his pain is and what we're trying to treat, and consider use of the other tools if and when he presents with anxiety or depression or other mental health impacts from his pain. And then moving to the next slide. It's now mid-July, so this was when I was hoping you'd all be able to see the brief pain inventory handout. So the brief pain inventory handout we have, so here he is, Brad. It was done in July of 2013, and the brief pain inventory is documented. It's actually, he's complaining of right shoulder pain, but it's been drawn on the left by mistake, but we left it there. And he's coloured in that his pain is all localised to his left shoulder, or to his right shoulder in our case. His pain scores, he's rating his worst pain as 7 out of 10, best pain is 3 out of 10, average of 4. What is he taking? He's taking some Tylenol and Brufen. He gets about 30% reduction of his pain. And in terms of interference with his general activities of living, he's moderately, it's moderately interfering with his life. So moving back to the presentation. So that's the first brief pain inventory he's filled out for us. Pain and stiffness has persisted. It's now radiating down his shoulder into the lateral 3 fingers of his hand. Wants to stop work, worrying and has a fear about harm, that he's going to harm his shoulder by working, and his boss is getting mad at him because he won't do his regular work. He's been referred to an orthopedic surgeon. So 7 months after this, he comes back again. So an MRI shows a partial tear of his supraspinatus tendon. He has an ortho consult, has had his ortho consult and is waiting for a surgical correction, or at least arthroscopy. He's still falling asleep but waking up lots of times through the night. Takes about 30 minutes to fall back to sleep, but not being woken by pain in the mornings. We do this is probably when I would start thinking about the DN4 questionnaire to find out whether his pain is somatic or neuropathic. And he's got burning pain into his left ulnar fingers with some electric shocking pains, but no cold. Some tingling, pins and needles feeling when you touch the hand, but no numbness or itching, and no hyperesthesia. So those things in the DN4 would be, I was going to get you to go through that and score that, but that suggests there's an element of neuropathic pain, but that's not the only thing. And then the next time he comes in, well, this is part of the same visit, sorry. He's, think whether or not we want to start an opioid in him. So far, we've not considered long-term analgesia, and so far he's had a realistic reason for his pain, but now he's not progressing despite all of the engagement with physiotherapy and exercise and ice and using medications which aren't opioids. So do you want to think about starting an opioid? So I'll go back to our visit template, and I'll show you how you can access the DN4. So as part of this visit template, you go down, and there's the chronic pain toolkit, which is part of this PSP module. So, if you wanted to open up the opioid risk assessment tool or the DN4, you'd just go along to the bottom, and there is the opioid risk assessment tool. You double click on that, and it would open the form in Intrahealth, which allows you to score his opioid risk sheet for whether or not he's at high risk of opiates. And I was going to try and get you to go through this based on what he discloses next and score him. So for those of you that haven't perhaps used this, the opioid risk score is whether they have a family history of drug abuse, or whether they have a personal history of drug abuse, whether they have a previous history of sexual abuse, and what age they are. And if you tick off these boxes in the Intrahealth, it will score it for you. And then you close it off and it'll save that score, and you're able to find that score again later. So if you want to access that form and it's not working, you go down here to your action list and you select forms. So you go to the form section. And again, if you haven't used any of the forms, this won't be populated, but once you have used them, you'll be able to find them there. And then you look for the form you want to look for is, you type in part of it, OPI I'll type in, and then there's the opioid risk assessment tool form. You double click on that, and there's the same form. So that's how you can access the form a different way. But ideally, I would like it to be that you double click on any of these and it opens the relevant form. So there's PHQ-9, GAD-7, etc. And they're all forms that will calculate your score and record that score in the EMR. So this guy, what is he going to tell us about his previous opioid use? He became addicted to painkillers years ago after an ankle injury, primarily Percocets. He obtained them from many doctors, but he also sourced them on the streets. He stole money from parents, family, and friends, and eventually he was admitted for a 28-day stay in a residential program in Ontario. So I didn't produce this presentation, Bruce did, and it was based on a true story. I'm not sure that I'd be prescribing this person opiates unless there was a clear sign that function was going to improve and it wasn't just pain. But I think, looking at this opioid risk tool, I don't need to score the opioid risk tool. He's pretty high risk. Even though he doesn't have a family history, he's pretty high risk for misusing or abusing his Percocets. He went to NA for 5 years. He's now stopped going to NA, which is kind of a sign. And he's not been using any opioids since, though. So how do we manage his pain? How would you manage this guy's pain in terms of using opiates? I think in the visit template there's and this isn't really about clinical questions, it's more about how we would safely prescribe something if you wish to prescribe. There's ways in which you can do a score to make sure that the brief pain inventory functioning level is going up, and it's not just that his pain level's going down. But if as part of the visit template, there's an opioid manager, which is a contract to start with prescribing opioids, and then looking at the brief pain inventory again after you've started prescribing it to see if function's improved. And I didn't show you the second brief pain inventory, but I'll show you his second brief pain inventory as part of this. So this is his second brief pain inventory, and now he's starting to color in his arm a bit with the pain. His pain on average, on the worst, is now 10, and it was 6 or 7. His best is 9, and it was 3. His average is 10, which sounds like he's catastrophizing a little bit. And then what is he taking for pain relief? Ibuprofen and Tylenol. In the last 24 hours, what medication relief have you received? And he was getting 30%, he's now getting 10%. And you can see at the interference with his functioning. Everything was in the middle before, and now everything's right at the top. So it's really interfering with his life. And this is before you're considering starting him on opioids. So would I get my MOA to give them a brief pain inventory to score before they came to see me? I probably would. Some of that would be, or would I, if the patient was coming in we have a walk-in clinic in our office, so the patient was coming in requesting painkillers in the walk-in clinic, and they were my patient, I would probably not prescribe anything, access that visit template, double-click on all of the resources I want him to fill out, and bring him back within a week. So that's a quick, easy way of doing that. But yeah, there's lots of ways you can get some of this stuff scored off before you get to see him or her.
So that when a patient comes back for his next visit, the mole brings him in, bang, and says, give him these pain and try to have him before I see him.
Yeah.
Is that
Yeah.
easy?
Yeah. That's pretty easy. Yeah, and especially if your first so we didn't do that. We did a SOAP note with our first presentation, and then we opened the visit template with his return. So the MOA would be able to access that visit template as part of that encounter and just use the hyperlinks or the action links on the side to say, hey, go through this visit template and give them this, that, and something else. And then the MOA doesn't have to find the correct form or use the correct patient information, and it's recorded in the chart that that person's been given that thing. So.
But does that, when the patient comes in and they bring them up, so when you're here, okay, does that flag, like right there in the moment? And the more it brings it up, it brings them into the air.
Well, you could, so there's, in terms of recording, if you're going to give that sheet to that patient, you could probably get the MOA to make a new visit template for that, for a new encounter.
I'm thinking, okay, it shows up at the front desk, you'd like that done before you see him that day. So you want somehow to have them.
Yes, so if you open...
You want her to give it to us, and ask her, I'd almost like to see this in your visit, would you do it beforehand?
Yes, yeah. And it's recorded that you've given it to them beforehand. So, not if you open the form and print the form, it's recorded like a WCB visit. So we have our WCB forms done before the patient sees us. So it'll be the same sort of process, is that you can go into your form section of the patient's record. I'll show you on that. If it's been opened already, and you can see that they've been issued that form. So there's on the patient medical record, there's a section called Forms, which is outside of the encounter, and you can see all of the tools so there's the opioid risk tool assessment that I opened and printed for that, or saved for that patient earlier. So anything that he's been given subsequently, you'll be able to see. Most of the usefulness of the visit template is having the ability to plug in an action list for my visit to say, hey, do I need to use the first pain visit template, or do I need to use the second pain visit template, or do I need to use the different parts of the pain assessment questionnaires, the BPI or the PDI? All those things are just a repository on the right-hand side. And then the smart fillable forms part are trying to help you in your daily, getting through the day in terms of scoring and recording that information so that you don't have to search through your documents or scanned documents again to find the score. You can find the score in a recorded, measurable, graphable way.